Well, good morning and thank you. We have been working on enhancing the value of our ultrasound to our patients for quite a long time. And so I was asked to just kind of review some of those issues. So what we're going to talk about is why this is important. I want to present a couple of instances where there's variation in the utilization of ultrasound, and then discuss recommendation for specific types of exams that we see. So just to start with, this comes from a TED Talk that's very interesting if you want to look it up, by Simon Sinek. And he is a leadership and management guru and talks about kind of how people that are successful, companies that are successful, both in business and professionally, approach problems, marketing, all kinds of issues. And what we typically do is we start with what, and then maybe we get to why. He suggests that we ought to flip that around. And the reason is that when we talk about what, you hear it all the time, just tell me what I need to do, or here's what you need to do. And there just isn't going to be much passion with that. So if we flip it around and start with why, and people understand why they need to do things or why they should do things, you're much more likely to get a response and get a sustained result. So here's one of the first reasons, and this talks about healthcare in the US in general. And I don't have time to go into the methodology at all, but if you want to look at it, you can look at the Commonwealth Fund and you can just Google it. But what this shows is our healthcare spending compared to other industrialized countries, and we continue to climb at a faster rate, and we spend way more than these other countries. And we've heard that. We had Jamie Orlikoff here 10 years ago showing us similar types of graphs, and they have continued. So the hope would be that if we're spending this much money, we're getting something for it. And the reality is we're not. With this graph shows, and I don't know if I can point it out, but you see the US down in the bottom right corner, and that's not where you want to be. You'd rather be up in the upper left corner. The y-axis shows healthcare system performance, and the x-axis shows the healthcare spending. And so our performance is worse than these other industrialized countries, and we do it at a premium. So with this talk has been going around for 2 decades nearly, and the Institute of Medicine came out with its sequel to Err Is Human, Crossing the Quality Chasm, in 2001, and they gave 6 aims for improvement of healthcare. And what those aims were, I just highlighted the one that kind of relates most to the ultrasound topic that we're talking about. We should strive for effective care. That means evidence-based, and we shouldn't provide services that aren't likely to provide a benefit. You should avoid underuse and also avoid overuse. We're really good at not underusing the technology, but we aren't as good as we could be for overuse. As we look at this, Goldilocks is one of my new best friends, and we should make sure that we don't do too much or too little. We should be aiming for just right. So for the rest of the presentation, I just want to talk about the various types of ultrasounds that we do, and remind folks that there are some indications for them, and there then is some finessing of it, and some of the recommendations that we have put forth based on these. So both the International Society of Ultrasound and OBGYN and the NICHD and ACOG have put out guidelines that routine first trimester ultrasound dating is not justified, is not needed. There are advantages, and I'll show you those in a second, of doing a first trimester ultrasound. And the Oregon Health Authority, although they haven't enacted this, they could at any time, they say that there isn't evidence to support routine first trimester ultrasound, but they're willing to pay for it because there is some suggestion, and it is ubiquitous. But they recommend it be done between 11 and 13 weeks, and this becomes important in a second. So one of the things that we do very well in portions of WHA is the Pathways Project actually limits the ultrasound to 1, and they don't do it when the patient presents right for prenatal care. They do it when you're going to get the most value for the ultrasound, and that's about 12 weeks. So what about the anatomy survey? Again, timing of this we do very well in WHA. The optimal time, according to ACOG, is 18 to 22 weeks. We recommend that we do it at about 20 weeks. And the reason for that is that most patients have had an earlier scan, and that earlier scan is of value. It confirms the gestational age, although you can date a pregnancy almost, not quite, but almost as accurately at 18 to 22 weeks as you can in the first trimester. You've got that done, though, with that early scan. You can identify multiple pregnancy at the later ultrasound, but it is much harder to diagnose chorionicity, so that is one of the clear advantages of the early scan. You can screen for aneuploidy if it's desired, as Karen just talked about, and we can do some early anatomy. And I'll give you an example of a case that I saw just a week ago. This was a patient who came in, had a 7-week ultrasound for dating. She didn't get a second one in the first trimester, which is very appropriate. She got her anatomy scan at 20 weeks, and lo and behold, there was anencephaly. So what we could have done with that is we could have identified it. You won't see it at 7 weeks, but you can see it at 10 to 12 weeks. And we could have seen it. She could have had an earlier termination. We did find it, so there wasn't a lot lost with that, but it did create a lot of angst around the time that it occurred. And with that, we would have had a safer, cheaper termination procedure. So that's one of the advantages of timing these things appropriately. The visualization is always also better. You can see more structures. We have less suboptimally visualized anatomy, and they have to come back for fewer follow-up exams. Now, one of the things that you guys can help us with is setting the expectations for the obese patient. We talked about this this summer when we talked about suboptimally visualizing anatomy, but we've had complaints through Quantros that come from many of these heavier patients. And if you let them know that it isn't as easy to see, that kind of tempers their expectations when they don't get the images that they would quite like. And that's helpful for us and helpful for you. This is a busy slide, and Tom alluded to it. It is at the back of your take-home points. And this is what we use to talk about what we're going to image. We have two types of ultrasounds. We have the routine anatomy survey that everyone gets, and we have the detailed anatomy survey that is indication delivered or indication driven. We have these structures. This is everything we look at on one of these ultrasound exams. And when we have a routine exam, these colored boxes with the X's are structures that need to be looked at and documented in every one of these exams. These are the structures that need to be looked at and documented in all of the detailed anatomy surveys. Because of a number of reasons, we don't want to be messing around too much with trying to figure out which one we should do. We want to look at all of these, but more importantly, we look at all of these because of we don't want two standards of care. And there's a whole lot more of these lower risk patients than there are the higher risks. So we're likely to find anomalies in some of these structures that aren't considered essential in a routine exam. These are the structures that we will call patients back for. It's arbitrary, but these are structures that the anomalies are more commonly found in. And these are the structures that are something that we really think is important. And there isn't guidance to tell this. This is a consensus amongst us. And so we are trying to put these things into the report so that you know when to follow these up. These are the detailed, and what these do is these mirror all of the anatomy. Again, arbitrary, but the way we've chosen to do it. And the one thing I want to call attention to is genitalia. That is not a required component on any of these exams unless there are twins. And so we do get reports or requests to bring patients back for this. That shouldn't be done. It's not often paid for, and it does create scrutiny. So we try not to put it in if we don't see it well, but sometimes it slips through as a suboptimally visualized anatomy. But again, it's not a requirement for any of these things. This is a slide you saw this summer, and I just want to talk now briefly about the utility of the follow-up scan for suboptimally visualized anatomy. We don't see anatomy in a significant portion of exams. That's not unusual. The heart is the most common and one of the more significant ones. They then took the 16,000 scans and followed up all of them that they had suboptimally visualized anatomy. They still couldn't see it all in 11% of these, so a significant number. And if you don't see it the second time, unless there's a really high risk or concern, they don't need to come back. But more surprising is that there were very few, I guess this part isn't surprising, there are very few anomalies that are found in those that have suboptimally viewed anatomy. And more disturbing and surprising is that those structures, there were twice as many anomalies found in those that were called normal. So just beware that this comment we have, this anatomy survey is complete, is maybe a little bit misleading. So here is when we should be following these patients up. It's important to note that the NICHD says that the utility of these scans in low-risk patients hasn't been established, and that's why we've tried to give some guidance with that document I just showed you, and we try when it's feasible in the comments to give guidance as to whether these patients need to come back or not. It is reasonable to repeat the exam if, depending on the limitations and findings. And again, we've tried to temper that and give some guidance. It isn't perfect because it's arbitrary in some situations. Follow-up is recommended in obese and other high-risk patients. Again, obese because it's harder to see and they're more likely to have anomalies. And we talked about the gender already. So what we recommend is that we follow up those high-risk structures, the two second columns for the type of exams, at about 22 to 23 weeks. You see in the comments 2 to 3 weeks for most of these, and but sometimes we do early anatomy for various reasons, and in those situations, make sure don't bring them back in 2 to 3 weeks, bring them back in 4 to 6 weeks so that they fall within this window. Fetal echocardiogram, this is just a list of the indications. The one I want to call your attention to is the bolded one. We get a lot of these for family history, and we haven't been very clear as to what that means, but I'm going to be very clear right now. It's mother, father, brother, sister. Those are the ones that should have follow-up anatomy. Second cousins, first cousins, uncles, aunts, there isn't an indication to follow or to do a fetal echo. So, and we see them, you know, the stepbrothers, second uncles, cousin's brother come for these fetal echocardiograms, and their risk is no different than the background risk. And the background risk is about 0.8 per 100 patients who get scanned. The mother and a sibling or a sibling is about 4 to 5%, and a father is about 2%. So those are what we're looking for with these. Growth is the other thing that we do a lot of, and we've put out the perinatal antenatal testing guidelines that have guidance for this, but 3 to 6 weeks is when you should assess growth. The earlier you do it, the more false positives you have. The later you do it, the more false negatives. So it's always a trade-off, and so you want to make your decisions based on risk. Longer intervals, 4 or even 6 weeks for conditions that are well controlled and appropriately grown babies. That's hypertension, diabetes, or dichorionic twins. The shorter intervals for small for gestational age, suspected growth restriction, or those that are very high risk. So 3 to 4 weeks, and it should almost never be shorter. It's like the grass. If you cut it every day, you're not going to know whether you cut it or not because it hasn't had an opportunity to grow. And the indications where you might want to do this are severe preeclampsia or abnormal